Well, thank you, Dr. Dwish, for chairing this session. So this is diabetes and endocrine emergency. It contains 10 topics. So it's mainly just an emergency with an update of each topic. So I hope everybody will get benefit from this mini symposium. I'd like to thank Dr. Dwish for his support, and I'd like also to thank postgraduate department for organizing such event. And lastly but not least, I'd like to thank Novo Nordisk for sponsoring this event. So the talk is yours, Dr. Muhammad. If you allow us to start the new,
please go ahead.
Okay.
Since I am as a moderator for this night, we have 5 topics. Will present by my colleague. We'll start by first topics about diabetic ketoacidosis. We'd like to mention we choose these topics. It will be, more interested to our colleague, the family physician, the internist, endocrinologist, as well as diabetologist. It's a common endocrine emergency. First topic will be diabetic ketoacidosis, will present by Dr. Abdul Ghani Saeed. Abdul Ghani, go ahead, please.
Okay. Thank you, Dr. Ahmed, for your introduction. So my topic is about diabetic ketoacidosis. I'll try just to give a brief so we could leave some space for questions. So I'll start with this clinical scenario, which is a common scenario for diabetic ketoacidosis. This is a 32-year-old woman who is known case of type 1 diabetes for 20 years. She was maintaining on multiple doses of insulin using Aspart 8 units pre each meal and Lantus 30 units at night. She presented to the emergency department with history of nausea, vomiting, and abdominal pain for 1 day prior to her presentation. She was diagnosed to have DKA and admitted through the emergency unit. So this is my outline. Start with the definition of DKA, diagnosis, precipitating factor, pathogenesis, assessment of severity, and outline about management of DKA. So what is the definition of DKA? DKA is a medical emergency which occurs mainly in type 1. However, it might occur in type 2, and some report it might occur in up to 10% of type 2 patient with diabetes. It's characterized by this triad: ketonemia, hyperglycemia, and acidemia. So how to diagnose DKA? To diagnose DKA, we need to have this triad, and this diagnosis or these cardinal diagnoses are taken from the British Diabetes Society, and their last update in 2013. So the use for ketonemia, a serum ketone of more than 3 millimole per liter. The main ketone has to be measured in serum ketone using the same like glucocheck machine, the point of care, or significant ketonuria more than 2 pluses on the standard urine dipstick. Second thing, the blood sugar more than 11 or non-diabetes mellitus. And why they put non-diabetes mellitus? Because now we have a new entity called euglycemic diabetic ketoacidosis. It mainly occur in pregnant ladies or as a rare side effect of a new class of medication which are the SGLT2. The third part of the triad is the bicarbonate is less than 15 and venous plus GAD less than 7.3. And why they didn't stress on the arterial rather than and on venous rather than the arterial, because there is really very marginal difference between the two. So you could use the venous pH as a tool for diagnosis in addition with the bicarb. So if you have this triad, ketonemia, blood sugar high or non-diabetes with bicarb of 15 and pH less than 7.3, you could diagnose a patient with DKA. So serum or urine ketones, what is the difference? In urine ketones, it measures the acetoacetate. So while the serum measures the 3-beta hydroxybutyrate. The 3-beta hydroxybutyrate ketones are the main ketones which are produced during diabetic ketoacidosis. They convert later on to acetoacetate, which persistently secreted in urine. So what is the implication of saying that? So the main ketones in severe decay is the 3-beta hydroxybutyrate. So if you don't measure the serum ketone or the 3-beta hydroxybutyrate, you might miss a few number or severe cases of diabetic ketoacidosis. Second thing, while treating patient with diabetic ketoacidosis, the beta hydroxybutyrate convert to acetoacetate, which result in persistent presence of ketones in the urine, even if the parameter shows there is improvement in DKA. And that's why we don't depend really just on urine ketone as or persistent urine ketone to stop the DKA protocol in our management. What is the pathogenesis of DKA? DKA happens if there is absolute insulin deficiency or relative insulin deficiency, and plus minus stress. So whenever the patient is having absolute or relative insulin deficiency, it results in increase in the counter-regulatory hormones like glucagon, catecholamine, or growth hormone. All of these hormones result in increase in gluconeogenesis and glycogenolysis, and both these mechanisms result in exacerbation of hyperglycemia. The other metabolic process which happens once there is insulin deficiency is the increase of lipolysis, because the cell feels as if there is deprivation from glucose since there is no insulin, so the cells cannot utilize the glucose. And because of the insulin deficiency, there is an increase of lipolysis, which results in increase of free fatty acids from the liver, which is metabolized to ketones, ketone body as a soul or the source of energy. And the accumulation of the ketones result in metabolic acidosis. There are 3 types of ketones which are produced in our body: the acetone, acetoacetate, and 3-beta hydroxybutyrate. So what is the consequences of metabolic acidosis? The problem, if the patient get metabolic acidosis, the metabolic acidosis exert a negative inotropic effect on the cardiac muscle. It exacerbates systemic hypotension via peripheral vasodilatation, to increase the risk of ventricular arrhythmia, to induce respiratory depression, especially with pH less than 7.00, and it exacerbates insulin resistance. If the patient is having DKA, we are expecting certain deficit in water and electrolyte. So the estimated water deficit in any patient with diagnosis of diabetic ketoacidosis is 100 ml per kg. It's between 30 to 100 ml per kg. So the estimated deficit is a 3 to 5 liter. And that's why, just the mainstay of management of DKA, you give fluid to rehydrate the patient. The most important electrolyte, what we care in the DKA deficit, is the potassium, and the estimated potassium deficit is 3 to 5 millimole per kg. You might be fooled with the high potassium during the metabolic acidosis, because just of the shift of potassium extracellularly. But just if you don't treat the potassium meticulously, it might result in severe hypokalemia because of the shift of potassium into the intracellular fluid due to insulin or due to the correction of metabolic acidosis. And that might result in severe hypokalemia with respiratory arrest, and it might result also in death. So what are the precipitating factors for DKA? The most common one is inadequate insulin treatment or compliance. It has been reported internationally as 1/4 of the DKAs are the new onset of diabetes. Acute illness is an important precipitating factor for DKA, mainly infection. But if you get a patient with DKA, you have to be sure that they are not having a cerebrovascular accident or myocardial infarction or acute pancreatitis. There are several drugs have been reported to precipitate DKA, like clonazepam, olanzapine, cocaine, or steroid. We shouldn't forget psychological stress is a cause of DKA, especially like these days, the exam days. In one of the local study, which was studying the pediatric group, it was published in 2015, showed that the median age of those with DKA was 11 years. The median duration of diabetes was 3 years. The new onset was 47%. So almost 50% of the pediatric group, they were having a new onset of diabetes at the time of the diagnosis of DKA. For those who were not a new onset or others with diagnosed with diabetes previously, the most common cause or the precipitating factor for DKA was non-compliance, which account for almost 80%, and infection account for almost 22%. The clinical features, these are the clinical features which is usually associated with DKA. The most common one is the nausea, vomiting, and abdominal pain. And you might find just the air hunger or cosmal breathing. In another local study, which is done by Dr. Musa Al-Malki in King Fahd Medical City and his colleague, it was published in 2016. In their series of DKAs, they show that the most common presenting symptom is the vomiting, nausea, and abdominal pain, which all of them, they are accounting for more than 70% of the causes. And the most common clinical signs was tachycardia, which account for 61.8%. On regard the precipitating factor, non-compliance to insulin regimen account for more than half of the cases, and it was the highest cause of DKA in their cohort. On regard the incidence and mortality, it's been reported also internationally that the incidence of DKA in different studies were ranging from 4.6 to 8 episodes per 1,000 patients with diabetes. And the mortality has fallen significantly in the last 20 years from almost 8% to less than 1% because of the good management plus the availability of ICU. So how to assess DKA? They can be divided to mild, moderate, or severe depending on the pH bicarbonate and the anion gap. So the mild is the one with getting pH between 7.25 to 7.3 with bicarbonate between 15 to 18 and high anion gap more than 10. Moderate DKA pH between 7 to 7.24 with bicarb between 10 to less than 15 and anion gap more than 12. And the severe one, the pH is less than 7.00 with bicarbonate less than 10 and anion gap more than 16. And one important thing in the assessment is the clinical picture. So if usually, I mean, the one with severe, they present with stupor or coma. The one with moderate, they might get like cosmal breathing plus alteration in their sensorium. So the most important point in the management that patient with moderate DKA, they should be managed in high dependency unit or ICU. So it's really important their management, it shouldn't be in the ordinary ward. And second thing, there is a flow chart or a flow sheet which need to be, I mean, filled by the nurse in charge or the fellow in charge of the patient. This is an example of flow sheet, which, I mean, you follow the glucose, pH, bicarbonate, and most important is the potassium. So what are the metabolic target during treatments? The most important thing we should care about having a target of reducing the blood sugar by 3 millimole per liter. You shouldn't exceed this, this level by far, because you might just induce a change in osmolality. The other aim, reduction in ketones by 0.5 millimole per liter, and increase in venous blood and venous bicarbonate by 3 millimole per liter per hour. And the most important, to maintain the potassium between 4 to 5 millimole per liter. So the line of management: hydration, with rehydration, insulin infusion, potassium supplement, and treat the underlying factor. So the main treatment, during rehydration, is the isotonic saline. Classically, we give 1 liter in the first hour, then another liter in the second 2 hours, then a third liter in the subsequent 4 hours. But this is not really just a rule that is a fixed rule, because you have to take care about the fluid overload, especially in elderly, or if you get patient with chronic renal failure, they might need dialysis, and you leave the fluid management to the nephrologist. So regarding insulin infusion, we tend to give continuous insulin infusion starting from 0.1 unit per kg, ranging from 5 to 10 units. So if the person weight 70, so he will need 7 units per kg till their blood sugar below 14. Then we use a sliding scale continuous infusion hourly. So we do 2 things. When the blood sugar below 14, we change the fluid to D5.9 or 0.45 saline, or to higher content of glucose, like dextrose 10%, to maintain high level of blood sugar, so you could give more insulin. You should monitor the venous pH plus bicarb and potassium regularly, and at least Q4 hourly. And initially, you might need to do it every 2 hours till you know the trend of improvement. The role of bicarbonate in DKA management, it is controversial. There is no large clinical trial in severe acidemic patient with DKA. So it's mainly like an opinion. So the clear indication during life-threatening condition like respiratory depression or hypotension. Some author, and in our protocol in Prince Sultan Military Medical City, we give it if the pH less than 6.9 or less. So it's a relative indication, but we have to be careful with the bicarbonate infusion, especially it might cause serious hypokalemia. So when to stop the insulin infusion protocol or the whole DKA protocol, and to start subcutaneous insulin, once you have a close anion gap which is less than 12, a serum bicarbonate at least 17 or more, and pH more than 7.3. Should cover your patient with a basal insulin, and then later on you give them subcutaneous insulin with the next meal, and then you do just an overlap of insulin infusion for 1 hour, then you stop the whole DKA protocol. In our hospital, Prince Sultan Military Medical City, we have like a DKA protocol, which is really an extensive one. The most important part from the fluid insulin is the potassium supplement. So potassium supplement is really an important thing in DKA management. You should start potassium supplement once you find the potassium between 4 to 4.9. So whenever you find the potassium level is normal, you should give at least 8 millimole of potassium chloride, 8 to 10 millimole of potassium chloride hourly. So it's the potassium supplement should be given hourly. And whenever the potassium level is this than 3 millimole, should hold the insulin infusion, correct the potassium, then later on you resume the insulin infusion. This is the continuation of our protocol. I think anyone can look at it. It's an excellent one, and I think rarely we have episode of hypokalemia with this protocol. What are the complications of DKA? Cerebral edema. These are usually rare, and that's why you need just to monitor your patient. This is the last slide.
Okay? Yeah, go ahead.
So it's mainly affect children. It should mainly occur in children. The second one is acute respiratory distress syndrome. Third, which is really very important one, is the severe hypokalemia. It might result in respiratory arrest and death. And there are reported of anecdotal cases of death because of severe hypokalemia during management of DKA. So you need really to be meticulous about potassium supplement. For a rare one, which is thromboembolism, like pulmonary embolism, and we find it in some patients with diabetic ketoacidosis. A very rare one, but we find it in one. I found in one patient is rhinocerebral mucormycosis, which is an opportunistic fungal infection that arises in paranasal sinuses. It occurs because of acidosis, and rarely is the rhabdomyolysis. And thank you very much, really, for your listening. Sorry for exceeding my time, Mr. Chairman.
Thank you, Dr. Abdulghani. Well done. We know it should be more than 20 minutes, but this is the time have been given to us. We'll move to next topics by our colleague, Dr. Balsam Bouhlega. She's a consultant endocrinologist. We are happy to have her in our institution. And she will talk today about hyperosmolar hyperglycemia state or crisis. Dr. Balsam, Zoom is yours.
Thank you, Dr. Muhammad. Thank you, Dr. Abdulghani, for arranging this and making me part of the speaking panel. Okay, so Dr. Abdulghani made it relatively easier for me to talk about hyperosmolar hyperglycemic state. For today's talk will be, I'm going to briefly go on the historical review, epidemiology, pathophysiology, diagnostic criteria, presentation, and then I will end with treatment, going through the most famous guidelines. So in the late 1800s, von Verschuch described what was called what he observed as diabetic collapse. He described patients who presented with unusual type of diabetic coma with severe hyperglycemia and no clinical features of what we know now is acidosis. He noticed that these patients were above the age of 40. They were well nourished, not like their patients with type 1 diabetes, who were usually cachexic, and with fatty infiltration in the liver and the heart, which we know now as fatty liver disease. So if you go, so this was in the 1800s, and the initial criteria that diagnosed HHS was only agreed upon 100 years later in 1971. I just want to point out that insulin was discovered in 1922. And then recently, with the most updates, HHS has been described in children, and there are guidelines to talk about the management of this disease in children. And I'll be talking about that. So epidemiologically, the true incidence of HHS is not really known, because not a lot of focus is given separately to HHS, separate from diabetic ketoacidosis. Usually they're lumped together, but we think it's estimated. Many studies have shown that it is rare. Less than 1% of hospital admissions related to diabetes are caused by HHS. But the most important thing to know is that the mortality is between 10 to 20%. And if you remember Dr. Abdel Ghani's talk, the mortality from diabetic ketoacidosis is only 1%. So that makes HHS carry 10 times more mortality than DKA. Mortality is usually related to the underlying condition and the precipitating factor. Which is interesting is that children, the incidence of HHS in children has increased significantly, 52%, with a reported incidence per year of around 4.5%. And remember that there are 20% of patients who will present with a picture that is mixed between HHS and diabetic ketoacidosis. So the three main features that HHS present with are severe hyperglycemia, hyperosmolarity, and dehydration in the absence of significant ketoacidosis. That's why the old name that was chosen for HHS, which was hyperosmotic hyperglycemic non-ketotic coma, was changed, not to cause confusion, telling you that some degree of ketosis may be present in patients who present with HHS, and not all patients will present with coma. Some of them will have altered level of consciousness, but some of them will not have that. And if we talk about pathophysiology, if you remember the pathophysiology chart Dr. Abdel Ghani showed, and you focus only on the part on the right, that's where the pathophysiology of HHS happens. So there is usually relative insulin deficiency with increased counter-regulatory hormones related to stress, which results in abnormal metabolism of lipid and protein. This eventually leads to increase glucose production and increase glycogen breakage, leading to hyperglycemia. Initially, the body compensates by the kidney trying to wash out that glucose, and with that, it loses a lot of water and dehydration and electrolytes. With time, if this is not corrected, and especially in elderly when they cannot reach fluids, like patients who have stroke or patients who are in nursing homes, there is worsening of renal impairment, and there is hyperosmolarity. So important question that comes up in patients with HHS is, why don't they develop ketosis? Well, a lot of human studies demonstrate that the concentration of insulin required to suppress lipolysis is only 1/10 required to promote glucose utilization. That's why type 2 HHS is more common in patients with type 2 diabetes who have relative insulin deficiency. So when you talk about diagnostic criteria, there are the American guidelines and the UK guidelines. The American, mainly the ADA, and then in the UK guidelines, which is the Joint British Association. And the cutoffs are very similar in terms of hyperglycemia, osmolarity being more than 320, the lack of significant ketosis, meaning that the pH should be more than 7.3, and bicarb should be more than 15 to 20, and usually there is altered mental function. You just need to keep in mind that unlike patients with DKA who present within hours of the DKA symptoms with abdominal pain, nausea, and vomiting, these patients usually presentation is more insidious, and symptoms have been going on for a couple of days before their presentation. The most common are hyperglycemic symptoms, And this eventually leads to neurological symptoms, including lethargy and focal signs, and being obtended. Why did they choose this level of 320 osmolarity? They've noticed that patients are more likely to develop neurological symptoms once their plasma osmolarity exceeds 320. And a very important presentation of HHS is focal neurological deficit, resembling stroke or even seizures. Precipitating factors, as mentioned with DKA, the most common precipitating factor is infection, and which represents more than 50% of the causes of HHS. Most common sites are pneumonia and urinary tract infection. 20% is the initial presentation of diabetes. There are underlying medical illnesses, especially when there's restricted water intake. Medications, as mentioned by Dr. Abdelghani. And in children and adolescents, in addition to infection, HHS has been described in patients with type 1 diabetes when they start going into DKA and they're start having hyperosmolarity, and they compensate their thirst mechanism by drinking huge amounts of carbohydrate-containing beverages, which pushes them into HHS with high osmolarity and high blood sugar. Biochemically, these patients usually have very high blood sugar levels. They have the sodium levels may be low, normal, or elevated. Low hyponatremia, which is known as pseudohyponatremia related to hyperglycemia, which needs correction. Usually a decrease 2 millimoles of sodium with each elevation of 5.5 millimoles of sugar above the normal, or 100 milligrams of sugar. Plasma osmolarity is usually calculated using the two main osmoles that cause serum osmolarity, sodium and glucose. And the sodium used is the actual sodium, not the corrected sodium. That's an important point and common MCQ question. As was mentioned by Dr. Abdelghani, there's a huge water deficit in patients presenting with HHS, even more than patients with DKA. In an individual that weighs 60 kilograms, it can reach up to 13 liters. An individual that weighs up to 100 kilograms, it's 22 liters. So when it comes to treatment of these individuals, one has to pay attention to look for the underlying cause, the precipitating factor of HHS, and trying to treat it. And then we aim to normalize the osmolarity, reduce fluids and electrolytes, and normalize glucose, hoping to prevent not common, but serious complications that can occur with rapid correction of plasma osmolarity and blood sugar. So very important principles in the treatment of HHS is fluid treatment. Fluid replacement is the key element in the management of HHS. This should not cause rapid changes in osmolarity because these may cause complications related to cerebral edema and cerebropontine demyelination, especially with the alteration in sodium levels. Insulin is not the first line treatment in HHS. It should be administered intravenously, not subcutaneously, and it should be you should use small amounts of insulin, aiming to keep the blood sugar at the higher level. And remember, when it comes to potassium replacement, there is no acidosis, so the shift that is seen in HHS is less compared to DKA, and a lot of patients will present with acute kidney injury and will have hyperkalemia. So one has to pay attention to that. I'll just, I brought this slide to talk about how the brain protects itself when there is hyperosmolarity. These are animal studies, but that show that when you induce hyperglycemia and hyperosmolarity, the brain protects itself by inducing iodogenic osmoles. So if you rapidly correct the plasma osmolarity, then this rapid change could cause osmotic gradient between the brain and the plasma. So that's why it's recommended to keep the glucose at a higher level of around 60 millimoles or 300 milligrams of glucose. This also shows, again, the same important factor. I'm just going to go through it quickly. This is normally, there's an equilibrium between extracellular fluid and intracellular fluid. When there is increased hyperglycemia, the fluid shifts from inside the cell to outside the cell and then goes to the kidney where the osmotic diuresis start. With time, there's contraction of the intracellular fluid and there is dehydration. So even the osmolarity goes up in the extracellular fluid. And then when you cause rapid change in give insulin and you cause rapid change in glucose levels, this shifts the water from the extracellular fluid to the intracellular fluid, causing volume collapse and dehydration. This is an old study, but I thought it was very important because it highlights the importance of IV fluid management in patients who have severe hyperglycemia. In this management, they tried. It was conducted in Austria in 1979. They tried giving patients isotonic saline and then checked, monitored osmolarity, blood sugar, and counter-regulatory hormones. And that they found with that the drop of osmolarity blood sugar was adequate only with fluids. And this caused reduction in counter-regulatory hormones. And they did not introduce insulin unless the patient the hydration would not cause further blood glucose lowerment. This again shows the same thing, that with IV hydration, you get a drop in glucose level, you get steady drop in osmolarity levels with slight elevation in sodium levels after correcting glucose levels. So when it comes to treatment of HHS, major society guidelines like the Joint British guidelines that was updated in 2012 that only looks at patients with HHS recommend the sole use of 0.9% sodium chloride as a permissible fluid to restore circulating volume. And they start by saying give 1 liter over the first hour, and then to target a reduction in osmolarity of 3 to 8 millimoles per kg per hour after the first hour for 6 hours, and the reduction of glucose of around 5 millimoles to target blood sugar between 10 and 15. They do not recommend the use of half normal saline unless there is the osmolarity is not being reduced with adequate hydration using 0.9 sodium chloride. Insulin should not be used unless there is evidence of ketosis or the blood sugar is failing to come down with adequate fluid resuscitation. If you look at the ADA guidelines, initially they have the same recommendation to start with IV fluids, usually normal saline, and then depending on the sodium level to choose your fluids between half normal saline if the sodium is elevated or normal, or to continue on normal saline if the sodium is low. The second difference between the British and the American guidelines is that the American guidelines usually recommend starting insulin, bolus, and then infusion with the same rate like DKA 0.1 unit per kg, which is different from the guidelines of the British guidelines, which only recommend using it if the glucose is not being lowered and at a much lower dose of 0.05 units per kg. This is the last point I'm going to talk about, which is the hyperglycemic hyperosmolar syndrome in children. The Journal of Pediatrics published these guidelines in 2011 talking about how to manage this syndrome in the pediatric and adolescents population. They talk about the same precipitating factor, same presentation, same criteria for diagnosis. The only difference they talk about is aggressive hydration. So they recommend really aggressive hydration with fluids, depending on weight, of course, because these are pediatric patients. They do recommend electrolyte replacement. And if the patient presents singly with HHS, they do not recommend starting insulin unless there is no drop of glucose with adequate hydration. And as you can see, the dose recommended by the society is, by these guidelines, is much, much smaller than the dose, a quarter or half of the dose that you would use for DKA. This is, of course, what the other recommendation they stress on is, in these patients, you really need to keep them in a high dependency unit where they can be monitored by professionals, medical care given by nurses, respiratory therapists, and pediatricians, and keeping the patient under monitoring, because cerebral edema is a real problem in this age population. I've almost come to the end of my talk. Just in summary, HHS is a rare but serious diabetic emergency with higher mortality rate compared to diabetic ketoacidosis. Hyperglycemia, hyperosmolarity, and dehydration are the hallmark of hyperosmolar status. It is more common in elderly with type 2 diabetes, but it has been reported in children and adolescents, and even with patients with type 1 diabetes. Treatment is mainly with IV fluids that can reduce both blood sugar and osmolarity. Most societies recommend that the initial fluid being used should be normal saline, and patients should be monitored both clinically and with serum osmolarity and blood sugar. If insulin is being used, a smaller dose can be started and the higher levels of blood sugar can be targeted. Thank you very much. Tried to keep time, so I hope